With a focus on advancing emergency care, Zoll delivers innovative, user-friendly technology designed for where and how you work, and for the patients who rely on the care you provide. Zoll is committed to helping you save more lives.
Thanks very much. So, yes, this talk will be about fluid resuscitation in children, and I guess it's a portion of the work that Ian referred to and Alan referred to, that they led as the co-chairs of our paediatric task force. In addition to my roles in Australia and New Zealand, I'm also a conflict of interest co-chair for ILCOR, and I can declare I have no financial or intellectual conflicts relating to this material. Make this work. This is where I come from. This is quite an old photo, actually, of Starship with Auckland in the background. Our skyline has changed considerably since then. However, the hospital hasn't. It remains very much the same. I've worked at that hospital for over 20 years now, and probably the first decade was dominated by a meningococcal disease epidemic in New Zealand, which particularly afflicted Maori and Pacific children who live predominantly in the North Island, the top half of the North Island. We were dealing with septic shock with high mortality rates, up to around 10% with that disease process, multiple times a week, once or twice a day in winter, which doesn't sound large numbers, but those were the children who actually had the disease, and that sits on top of the 50 or 60 other children with petechial rashes who came in with the concern about could that actually be what's going on. So this was a huge workload, and it certainly triggered an interest on my part in were we doing the right thing? Because those of you who have managed these sort of kids, you know that in more sophisticated healthcare settings where you have inotropes and ventilation and ICUs, the ED practice, filling these kids up with fluids to get adequate perfusion, often leads to them starting to froth. They start to swell in all parts of their body, and you do need your intensive care colleagues to rescue them. And we need to bear this in mind as we think about the need to tweak our practice in different settings, and I think that's quite relevant to our consideration of the evidence as we go through this. Early circulatory compromise is extremely difficult to recognise in children, and the individual clinical signs, if you look at them by themselves, are quite unreliable. They tend to be a bit subjective, and they tend to be difficult to document in a way that you can track them over time in an accurate way to pick the deteriorating patient. It's really clear that if children progress to circulatory collapse where their blood pressure drops through their boots, that the mortality and morbidity goes really high and the resuscitation is really difficult. What we look at is heart rate, cap refill, blood pressure, peripheral pulse volume. We look at the child's alertness and behaviour. We look at skin colour, temperature. We can measure peripheral to central temperature differences. This is all the stuff we're doing without the invasive monitoring that you might get at the stage you're moving through to ICU. You look at respiratory rate and effort and urinary output. Most of these things are either low precision, so cap refill doesn't change very quickly. Any child undressed in a resus room tends to have low cap refill, even in an environment like Singapore, after 15 or 20 minutes. Peripheral pulse volume is actually very subjective. Skin colour and temperature is very subjective. The one thing you can actually track over time is heart rate. But the problem with heart rate is the needle in the haystack problem, because there are so many children coming into our emergency departments with quite high heart rates on the basis of discomfort, anxiety, fever, all those other things that put your heart rate high. And to pick out the one or two who are in the early stages of compensated circulatory compromise is very difficult. You have to put it all together, and over a lot of practice and seeing a lot of really sick kids, I think people do get better at that gestalt mental picture image of what these children look like, but even that is not easy. So we were very interested in doing fluid resuscitation in septic shock. This question was not addressed in the previous cycle of the ILCOR evidence review. We did a slightly different question the previous cycle, which was about crystalloid versus colloid. This is more about restricted volumes of fluid versus bolus therapy. So this question, the way it's formulated, created for myself and Pete Meany, who was my co-evidence reviewer from Children's Hospital of Philadelphia, an immense amount of work. And when you tease it apart, there are multiple questions included in what we thought was an initially reasonably tightly framed question. So we said infants and children at septic shock in any setting. So the any setting created us some difficulties. And we talked about restricted volumes of crystalloid or non-crystalloid in comparison with 20 mils per kilo boluses of isotonic crystalloid. And we looked at these outcomes listed at the bottom. So as Alan outlined before, the way GRADE works is that you evaluate the literature set that you have as it informs each of these outcomes. So for all of these questions, we basically looked at whether they influence survival to discharge, incidence of complications, need for ventilation or vasopressor support, the time to resolution of shock, hospital length of stay, the total volume of IV fluids administered, ventilator-free days. And we ranked those in terms of how important we thought those outcomes were. We included all the human studies, infant and child, controlled trials, or case series. We looked at terms such as septic shock, and some synonyms, and we included malaria and dengue shock syndrome and other things. We did kick out all the adult stuff. We were interested specifically in paediatrics on this question, and we kicked out trauma and burns because we thought that was going to contaminate the information we're after. And we kicked out of any studies where there wasn't actually a comparison group with the isotonic crystalloid bolus. We had professional librarian support through the ILCOR structure, so the search was very broad and inclusive, and so we screened 2,657 papers to come down to, some of them you can look at the title and say it's obviously just been picked up and it's something to do with something totally irrelevant. Most of those 2,500 we looked at the abstracts. Then we came down to 27 that were reviewed in detail in full, and we ended up excluding a number of others, having reviewed them in full and realising they didn't meet our criteria. And we ended up with 16 in our evidence profile tables, including 10 RCTs, which I think, as Ian's pointed out, that's quite remarkable in the paediatric literature. We don't get many questions where we have that many RCTs. 6 non-RCTs. We did produce these bias tables. One of the things to look at is that column reflecting total numbers of patients. And also the population on the right, it describes the type of shock population that was examined in that particular paper. So it became important as we were thinking about this question whether there was intensive care support available in the form of inotrope and ventilation strategies. But we did find that papers tended to fall into a number of quite good papers on dengue shock syndrome, some on non-specific septic shock. There are a number of papers on severe malaria. And then most importantly, there was the Maitland trial, which I'm going to go through, which used a different definition of severe illness with some signs of poor perfusion. So those were the RCTs. You'll see most of them are quite small. However, there were some big ones. There was a biggish one on dengue shock syndrome, 500 patients. And of course, the Maitland trial, 3,100 patients, which is a superb piece of work, but ended up being downgraded in terms of the direct applicability to the question that we were asking. But still, probably the best evidence we've got on a lot of this stuff. And then we had some non-RCT data. Alan referred to the Carcillo paper earlier, which is that study that we've based a lot of our fluid bolus therapy on. Actually, a remarkably low number of patients, 34 patients. So if we look at dengue shock, and I'm very conscious that there are a lot of people in this room who see dengue shock on a daily basis or much more frequently than I do. We do get imported cases of dengue in Auckland, where I work and live, because we provide services and a lot of toing and froing from the Pacific Islands. But we don't have any local transmission. So there were 3 quite high-quality RCTs. They were from Vietnam and India. These in settings where ICU support was available. Basically showing no difference between colloid and crystalloids for critical outcomes of complications and time to resolution of shock. None of those included a control group who received actually restricted fluid volumes. So it didn't totally inform the question we were trying to ask. The mortality was extremely low, which I find fascinating in comparison to other forms of paediatric shock. Because usually we're dealing with much more significant mortality than this. And it does provide some indirect support for the role of fluid bolus therapy in dengue, but it's kind of going back to that Carcillo-style data that Alan pointed out, which is, we do it and most kids survive, or they seem to survive, but we haven't actually got that real direct comparison. And there was also a retrospective review, which is pretty low quality, which suggested lower mortality with more aggressive fluid therapy as well. Severe malaria is quite interesting, as I'm trying to think about this in a different way, because the thing about severe malaria is a lot of these children are profoundly anemic. And of course, if a child is already significantly compromised and in shock from another disease process, actually filling up their circulating volume with crystalloid or non-oxygen transport fluid, it might not be the best thing to do for them. Maybe they need blood. And some of these studies do include blood transfusion for these kids in addition to the other interventions, and so that also contaminates your kind of comparison and how you think about that. Those studies, again, didn't use restricted fluid controls, and really we don't get a strong signal here of there being any difference between crystalloid, colloid, or between different approaches. Now, the sort of undifferentiated septic shock refers more to the kind of groups of kids that I've dealt with in the past, the meningococcal disease, the children with gram-negative sepsis of other forms. Alan again referred to xanthanam. It's a combination of a whole goal-directed package comparing 40 mils per kilo, quite an aggressive approach. That's the kind of stuff we used to be doing with our meningococcal disease, 40 to 60 mils per kilo, syringe it in as fast as you can, and comparing that to a more gradual but still bolus approach of up to 60 mils per kilo over an hour. They didn't find any difference in mortality or time to resolution of shock. They did have ICU level of care there. And then the Chopra study actually looked at 3% saline in a restricted volume, 15 mils per kilo over 30 minutes, versus their other, which was 20 to 40 mils per kilo of normal saline. And again, 2 different ways to do it. No differences in mortality, time to resolution of shock, or duration of ICU stay. So not really much of a signal there about which is the better way to go. Now this is the big paper. This is the Maitland and collaborators study. Very large numbers, 3,141 children. They had some stratification within that. So importantly, they had 29 children who had significant hypotension at the time of presentation. They were excluded from the stratum where there was a control group of no bolus therapy. They didn't feel able to withhold bolus therapy from children with a collapsed circulation. And the mortality in that small group of 29 children who were all assigned to one type of bolus or another was very high. The mortality there was in the region of, I think, around 50 to 60% in that group. So I think most of the information in the FEAST study actually comes from the children who did not have hypotension. So they had a severe febrile illness, with some signs of poor perfusion, but not all of the standard definitions that make septic shock. Okay. So the other interesting thing, which is helps you put this in perspective according to the environment in which you work, is that significant malnutrition and gastroenteritis or gastrointestinal disease presentations were excluded. Now, children with severe malnutrition have pretty major challenges with gram-negative sepsis and GI disease, and they have high mortality rates, and there are recommendations which have limited evidence base for using different types of fluids, less concentrated, higher potassium, lower sodium Dallow solution, the WHO protocol. Didn't find anything which would support one form or another, but that wasn't the question we were looking at. I think this group we don't know anything about in the point of this question, so if any of you are working in environments with significant malnutrition or go there to visit, as a lot of people do, to assist local health workers, I don't think this material can apply to that group of kids who are in deep strife. Now, the children with significant hypertension, as I mentioned before, were not placed in a control group, so they all got either albumin or normal saline boluses, but they still had about a 60% mortality. So that the children who were stratified into all three groups, so control, no bolus therapy in the first hour, or normal saline in the first hour, or 20 to 40 mL per kilo of albumin in the first hour, all of them received subsequent maintenance IV fluids, antibiotics, and the type of supportive care that was available there. Now, that did include the availability of some blood. The initial protocol did change a little bit along the way, but not in a way which I think affected the outcomes. They found there was no difference between the two groups which received either albumin or saline bolus, but the really surprising, stunning, disturbing result was the excess mortality in the bolus therapy groups versus the no bolus therapy groups. So it was a relative risk of 1.545 mortality if you receive boluses in the first hour, with an absolute excess mortality of 3.3% in those groups. So this challenges, the emphasis we've had on bolus therapy for kids with circulatory compromise, obviously. And there's been a lot of thinking hard about it and trying to say, well, this is Africa, these kids might be different, the ICU support might not have been there. What does it actually mean for the overall practice of emergency paediatrics? So the first thing to consider is that it's hard to compare the results of this study with other studies because of the different entry criteria. The second really important thing, and I think that's been emphasised in Alan's talk, was the lack of inotrope and ventilatory support, which is the kind of the rescue therapy that we need for our initial aggressive fluid approach to children in septic shock in the environments where we work with that. However, it's interesting that Maitland did a lot of subsequent work of subanalysis and published in a couple of other papers which tried to look at these potential confounders and influences, and she described that there was no significant differences in the rate of pulmonary edema or cerebral edema between the groups. So that didn't, in terms of how much she could control for that didn't seem to be the issue. She also tried to analyse in terms of what the presenting syndrome was like. Was it a predominantly respiratory kind of illness? Was it a predominantly circulatory kind of illness, or more of a CNS? Because, fill up bolus fluids with a kid who's predominantly come in comatose. Maybe they've got meningitis. Might not be right, but she found actually that mortality difference between bolus and no bolus was persistent across all of those subgroups as well. Importantly, 57% of the children in this study did have malaria, and many of these had very severe anemia. And again, she looked at those with profound anemia versus others, and again, the effect did seem to persist. Now, these are all kind of post-hoc analyses, and you've got to be careful because it's really hard to actually eliminate the confounding if it's not in your study design and really well thought through at the start of the study. However, there's still cause for concern. So where we've ended up in terms of our treatment recommendations through our task force was that we do suggest using initial fluid boluses in infants and children with shock with subsequent really careful, full package to look at all the features of the child patient reassessment. And we recommend that with severe sepsis. We recommend it with severe malaria. We recommend it with dengue septic shock, or dengue shock syndrome, I should say. Weak recommendations based on low quality of evidence throughout. We didn't identify any evidence to suggest a benefit for alternative types of fluid versus isotonic crystalloids for bolus therapy, using all of our outcomes. And we did suggest against the routine use of bolus intravenous fluids for children with a severe febrile illness who are not in shock. Now, that was a weak recommendation, even though it was such a huge study, a really fantastic piece of research. And I've really struggled with calling it low-quality evidence. It's only low quality in the context of this question, magnificent piece of work. But we don't know, if we generalise that to children around the world, what's the mix of kids in that definition? Would we cause harm by making a strong recommendation against the use of bolus therapy? Would we be preventing a helpful therapy from being applied to children? And the underlying message is, regardless of therapy administered, you've got to reassess so that you're detecting deterioration. So the bottom line is one size doesn't fit all, whether you're talking about drain grates in the road or whether you're talking about fluid therapy in children. I'll just take a quick moment to say we do have a conference coming up in Auckland. We'd be really welcome to see you there. 7th of night, not much time to plan now. So, and
thank you very much.